Everyone, here Dr. Imran. I am a laparoscopic, bariatric and metabolic surgeon practicing in Dubai, UAE, and also director of obesity clinic, Iranian Hospital, Al Wasl Road, Dubai. I have started bariatric surgery since 2005 and progressively. So first I start at that time gastric bending, then gastric sleeve, Roux-en-Y, and anastomosis, gastric bypass, BPD, all types of related surgeries, and then now SASI and gastric plication, staple-less SASI, that is also gastric plication with ileal bypass, especially for diabetic patients and especially for the patients who are suffering with metabolic syndrome. So this is my journey of metabolic surgery. I am also fellow of American College of Surgeons. I am also fellow of American Society for Bariatric and Metabolic Surgery. I am also fellow of Minimal Invasive Surgery. Today I want to talk about metabolic impact of bariatric surgery. I will also share my personal experience. During this period, I performed more than 2000 cases of bariatric surgery, and hundreds of the patients who were suffering with diabetes or metabolic syndrome. The indication of surgery was only metabolism, only metabolic surgery. They were not much more obese, and I did surgery and excellent results. I also share my personal experience, especially in such a cases, and now my follow-up. I have my cases more than 10 years. I am following such a cases. I want to discuss about metabolic impact, because bariatric surgery or obesity surgery, it is also called weight loss surgery. So I will what will be my agenda in my discussion? First, a brief introduction of bariatric surgery or weight loss surgery, metabolic basis of bariatric operations or bariatric surgeries, conventional indications, emerging indications, risk stratification, and video presentation at the end. So first of all, I want to define obesity, especially for my viewers. So what is obesity? So what is because obesity, we have a standard, or we have a criteria. On the basis of this criteria, we can define obesity, that is body mass index, BMI. How we measure this BMI? It depends on the height and weight of the patient, height in meters and weight in kilogram, kg. So then we divide, because we multiply height. If someone is 1.8 meter, then we multiply 1.8 multiply by 1.8, we achieve a number. And then we divide weight. If someone is 200 kg, we divide by this number, so the result will be BMI. So that is called body mass index. So the normal range in overall all over the world is, that is the standard, is 20 to 25. And when this BMI is 25 to 30, we call it overweight. 30 to 35, it is class 1 obesity. 35 to 40, it is class 2 obesity. And 35 above 40, when BMI, this is class 3 or morbid obesity. So what is the history of bariatric surgery? If we see, so first obesity surgery started in 1953 by Richard Barco, and at that time it was ileal bypass, and at that time, because there was no laparoscope and all the surgeries were open surgery, and he is the pioneer of bariatric or obesity surgery. So follow this ileal bypass. Scapinaro, he is a big name, he is a legend, he is from Italy, and he started duodenal switch. So, and also BPD, because this scapinaro mostly started biliopancreatic diversion and duodenal switch, and then followed by this Roux-en-Y gastric bypass, and they are pioneer of bariatric surgery. Sleeve gastrectomy has been started by Michel Garnier in 1995. Overall, Michel Garnier is a BPD surgeon, and at that time he was practicing in USA, and in a very heavy patient, and I think high risk patient, because when they do this duodenal switch, routinely first they do sleeve gastrectomy, and then they bypass that area of duodenum with the duodenal-ileal bypass, because when he finished sleeve gastrectomy and he was going to prepare for second step, patient condition was not good, and anesthesia he asked, so we must shift the patient to ICU. So they shift the patient to ICU with only sleeve gastrectomy, and further they see patient achieve good results. So at this time, so Michel Garnier thinks, so we can do only sleeve gastrectomy. There is no need to add such a risky procedure like jejunal-ileal bypass in such a patients. And then he start this sleeve gastrectomy, and in 1997 and also further he also start this surgery, sleeve gastrectomy, by laparoscope, and laparoscopically he follow this, and now in the world the most common bariatric surgery is sleeve gastrectomy. In 1997, Professor Robert Rutledge, he is originally a trauma surgeon, he is also from USA. In a case, so that case was a case of trauma, and also patient was obese at that time. Also they preferred to do open surgery. He did such a this gastrectomy and loop gastrojejunostomy, and then he see patient also lose weight. So this was the thinking about, and also he start to do mini gastric bypass. That this it take time evaluation. Now we have mini gastric bypass, but at that stage they start this, and progressively there were some variations in this surgery, and now we have the proper type of mini gastric bypass. And follow up this mini gastric bypass, Professor Carbao, who is my mentor, and I am also trainee of Professor Carbao, Spain, and from Valladolid, that is a city, beautiful city north of Madrid. So he did some variation in mini gastric bypass, and he named this surgery one anastomosis gastric bypass. And now I personally follow one anastomosis gastric bypass, because my mentor is Professor Carbao, and excellent results. Following this, so Professor Antonio Torres, he is also our good friend, and he is also from Spain, Madrid, and with some variations he start SADI, that is also a sleeve gastrectomy with the duodenal, this is the loop duodenal-ileostomy, and excellent results. And this is in also especially morbid obese patients with the metabolic syndrome or diabetes, we can achieve excellent results with SADI, that is also sleeve with duodenal-ileostomy. Followed by ileal interposition, that has been started by Surendra Oghale and as well as Rubinho. Rubinho is also a big name. He is basically from Brazil, and at that time he was practicing in USA. And because the main target was metabolic syndrome, and to treat these cases who are suffering with syndrome, no need to lose weight. In such a cases, it was amazing. Just because what was the thinking of this? Because overall I will discuss in further. So about small intestine and role of hormones. So Professor Oghale start ileal interposition. Just they change the position of ileum with jejunum. Then ileum was near stomach and jejunum was at the place of ileum, and with this they achieve the target of metabolic syndrome treatment. That was the main target. And then single anastomosis with the sleeve gastrectomy that has been started by C.K. Huang from Taiwan. SASI, that is also single sleeve gastrectomy or single anastomosis sleeve with ileal bypass, started by Santoro and Tariq Mehdi. And also I have some changes in 2016. I have started staple-less SASI, 35 plus 1 comorbidity, 40 without comorbidity. So we can do surgery in a patient with BMI 30 plus diabetes. I have started this. This is staple-less SASI, and in this surgery we never use stapler and just with gastric plication with ileal bypass. Just some pictures I will show for my viewers, so you can see the different types of surgeries we can see here. This is duodenal switch, BPD, and also I will mention further, this is a sleeve gastrectomy. About 80% portion of stomach we remove in this surgery. And here you can see this is mini gastric bypass. Just as we never remove in stomach in this surgery. And you can see a small pouch of stomach, and then we attach a loop of jejunum. It depends on the BMI of the patient. Then we attach this with this stomach pouch, gastrojejunostomy, and this is called mini gastric bypass. Here you can see that is classic gastric bypass or Roux-en-Y gastric bypass. Here also we have small pouch, and you can see this is 2 anastomosis gastric bypass. Again, it depends on the patient and patient BMI. So how much length we bypass, because first of all we measure small intestine, small bowel, and then we decide how much the weight of the patient and other comorbidities, age of the patient, gender of the patient. Then we decide how much small bowel must be bypassed. This is also loop duodenojejunal bypass with sleeve gastrectomy that has been started by C.K. Huang from Taiwan, and this is also one the type of this metabolic surgery. And this is ileal interposition that I have mentioned. So the distal part of ileum, they just exchange the place of jejunum with ileum to achieve that target. The target is rise of GLP-1, glucagon-like peptide-1 hormone, that will be rise when undigested food particles and nutrients touch to ileum mucosa. At that time GLP-1 rise, and then we achieve that target for the treatment of metabolic syndrome. So here you can see this is also type of anastomosis gastric bypass, and also started by my mentor Professor Carbajo. We can see here, and there are some little difference between mini gastric bypass and one anastomosis gastric bypass. This surgery is excellent for the patient suffering with diabetes as well as obesity. Also we can see here, this is SADI that has been started by Professor Torres. So excellent results also for diabetic patients. So this is also another type. So there are different types. We can see the main target is same, but with different types we can achieve our results. So this novel procedure has been started by mine. I have started this surgery in 2016. Now I have excellent results. I have completed my data. And now in this surgery, what I do, I never use stapler in this surgery. I prefer this surgery in low BMI cases, patients who are suffering with diabetes. Excellent results. What is our target in such a situation? We do gastric plication, and also I measure small bowel from this ileocecal. Again, it depends on BMI of the patient. In some cases, the BMI is high, then our common channel is 250 centimeter. If BMI is low, then 300 centimeter, 350 centimeter. It depends on the patient, and all the surgery is staple-less. we call it staple-less SASI. So just now you can see what I do in such a surgery, gastric plication with gastroileostomy, and there is a loop anastomosis between stomach and ileum, and we can achieve the same targets, especially also in obese people as well as patients only suffering with diabetes, hypertension, dyslipidemia. We have about 20 types of comorbidities till you can't believe. So this the quality of life, we don't have any specific definition of quality of life, but we can see. So quality receptor, PPAR gamma, these are the insulin resistance genes. And what will happen, so this due to obesity, and then we can see here obesity, insulin resistance. When this occur, what will happen? Now we have two types of beta cell in pancreas, sometimes normal beta cell, sometimes susceptible beta cell. In case of normal beta cell, so increased beta cell function, when there is a resistance to insulin, the function of beta cell will be more to compensate that resistance. When pancreas and beta cells start to work more and more to compensate that, that is very important for pancreas. And what will happen? Then increased beta cell growth, hypertrophy of beta cell, that cause normal glucose tolerance or compensatory hyperinsulinemia, because in our body then insulin is very high to compensate that resistance to insulin. And sometime when our beta cell are not normal condition, what will happen at that time? Beta cell dysfunction or growth genes are like HNF1 alpha, HNF4 alpha, KIR 6.2, TCFL2, and mitochondrial. We have these genes and changes in such, when if we detect this one, if beta cell is not normal, we have such a situation. And then what will happen? And insulin resistance, then beta cell dysfunction, beta cell cannot do function, beta cell apoptosis. So then impaired glucose tolerance and type 2 diabetes. In patients with type 2 diabetes, we see the main dysfunction of this beta cell. And then we can see, so what will happen in environment, for example, high fat, any high calories and less physical activity is dangerous for the patients, because environment is also cause diabetes. Now we can, what will be our result in such a situation? In when patient is suffering with IP also increase after surgery, that is a good thing. And GLP-1 always rise in such a surgeries, and PYY also rise. Overall GIP decrease after surgery, bariatric surgery, because GIP is also increased resistance to insulin. So here if I see, so what is the, how it affect gastric bypass, or we can see here component of gastric bypass. I can explain easily here. If you can see, first of all we make a pouch. I will explain step by step, that will be very easy to understand what is happening in this surgery, how this surgery affect. So if we see here, so this is first step, we make a small pouch with stapler. This is gastric restriction first. So then we exclude the distal stomach, exclude. Stomach is inside the abdomen, we never remove this. But here we have ghrelin hormone in fundus. When we bypass this area, then this ghrelin hormone is here. When we bypass this area, ghrelin hormone is increased resistance to insulin, and then we can see, so resistance to insulin will decrease. So again we can see the third step. Our third step is exclusion of proximal intestine from alimentary flow, that is duodenum. And we have two theories, I will explain further, and also these theories were by Rubinio and Professor Michel Garnier, that is foregut and hindgut theory. So in foregut theory, when we bypass this portion duodenum, so also we decrease resistance to insulin, as well as so we increase some incretins, that incretins routinely secrete from this duodenum, and they support to insulin for their effect. So due to this we bypass this area. And fourth one is early delivery of ingested nutrients to jejunum, that I also earlier asked. When this undigested food particle go bypass of ileum, that will be metabolic impact. Like this, you can see delivery of partially digested or undigested nutrients to the distal intestine. That is the most important part of this surgery. And then we can see also now segregation of digestive secretions from alimentary flow, as well as we can see partial, sometime we can do here partial vagotomy. This is overall structure of component of gastric bypass procedure. So when we do this gastric bypass, we can see the result of our that we can achieve of metabolic syndrome and treatment of metabolic syndrome. The main part of this metabolic syndrome is diabetes, and then we can see that metabolic impact of bariatric surgery or weight loss surgery, how it is possible to treat this diabetes. So same thing you can see here in this area also. I can explain, when we do these changes, we can see here. So there are different parts of multiple organ involved for the treatment of metabolic syndrome or diabetes. We also have some neural effects, we have hormonal effects, our effect on brain, pancreas. So everything we can see, and also there is altered mitochondria. And then we can see in ileum the high GLP-1, high PYY, high oxygen, and you can see these, and oxygen will rise because routinely when we in our inspiration, when we take in our respiration, so what will happen? Oxygen stuck only in stomach because there is a pylore, and then we have our normal flora is anaerobic. But after gastric bypass, we can see our normal flora will be changed, and then it will be a oxygen, or we call it so because aerobic normal flora, and there is also impact of normal flora. So this is our discussion, and then hopefully it will be effective for you, and then I will start my discussion and clinical implication of our surgery.